All right, welcome back to the Explainer. Today, we are putting on our detective hats. Seriously, we've got a real medical mystery on our hands, a symptom that's pretty common, but always alarming. So let's get right into it and start investigating the case of lower GI bleeding, beginning with clue number 1.
So let's just cut to the chase with a really direct question. What does it mean when you see blood where it's not supposed to be? I mean, it's a universal signal, right? It's your body basically sending up a flare telling you that something is wrong. And for our mystery today, this is the exact moment the investigation kicks off.
So that bleeding, that is our inciting incident. It's the first major clue that tells us, hey, we need to start asking some serious questions. Think of it as the body's emergency alert system, and our job is to figure out where that alert is coming from, and more importantly, why.
Now, to solve any mystery, you've got to know the lingo. So let's get on the same page. The focus of our case file is lower GI bleeding. All that means is that the bleeding is coming from the lower part of the gastrointestinal tract. We're talking mainly the colon and the rectum. Just knowing that location is a huge first step in narrowing down our search.
Okay, so we've got our crime scene defined. Now it's time to line up the suspects. You know, in any good detective story, there's a whole cast of potential culprits. And believe me, it is no different here. Each cause of lower GI bleeding has its own unique signature, its own way of operating, and we need to look at the evidence to see which one fits the crime.
Now, this is where our investigation gets really interesting, because one single question can immediately split our list of suspects right in two. The very first question a doctor, our lead detective, is going to ask is simple. Does it hurt? The answer, whether it's yes or no, is this huge fork in the road that helps us focus our investigation from the get-go.
And here is a perfect example of what I'm talking about. Look at this. On one side, you have an anal fissure. That's typically painful. On the other side, internal hemorrhoids, which are kind of famous for causing painless bleeding, especially after you go to the bathroom. Both show up as fresh blood, but that one clue, pain, sends the investigation into completely different directions. Of course, anal fissures aren't working alone in the painful category. The list of culprits also includes things like thrombosed hemorrhoids or a perianal hematoma, which is basically a sudden, painful lump. And then there's a more serious suspect called ischemic colitis, which causes severe pain because the colon isn't getting enough blood. In all these cases, pain is a very loud clue. But what about the silent bleeds? This is where the lack of a clue is the clue. The suspects here include some serious ones, like rectal cancer, or something called angiodysplasia, which is more common in older folks. And for younger patients, a big suspect for heavy, painless bleeding is something called a Meckel's diverticulum. See how age just became another vital piece of evidence in our case? You know, sometimes the evidence is more subtle than just blood. The slide mentions PR bleeding, which is just doctor speak for bleeding from the rectum, but look at the other clues, mucus discharge, or that feeling like you haven't completely finished. Those little details can point towards suspects like ulcerative colitis. It's not just if there's bleeding, but what else is going on that helps crack the case. Okay, let's pivot for a second to a totally different scenario. What happens when the evidence isn't subtle at all? What happens when it's dramatic, it's sudden, and it's incredibly urgent? This is the massive bleed, the highest stakes part of our entire investigation. So in a massive, painless bleed, our list of prime suspects gets pretty short pretty fast. We're now looking at conditions like diverticular disease. We also see some familiar names from our other list, like angiodysplasia and Meckel's diverticulum, because they can cause major blood loss too. The pressure here is on, and we have to identify the culprit, and fast. So, we've lined up our suspects, from the painful ones to the silent ones to the really dramatic ones. How do our detectives, the doctors, actually gather the hard evidence they need to make an arrest, or a diagnosis? It's time to open up the forensic toolkit. Let's stick with that high-stakes scenario. A patient comes in with a massive bleed. The clock is absolutely ticking. There's a very clear, very logical protocol that investigators follow to get control of the situation. So, what's the first move? First things first, you can't investigate a crime scene while it's still in total chaos. So, step 1 is always resuscitation. Doctors stabilize the patient with fluids. Only then does the real investigation begin, starting with a scope to rule out an upper GI bleed first. If that's clear, they move on to a CT angiogram, which basically acts like a GPS tracker to pinpoint the exact source of the bleed. Now, here's a fascinating little detail, a tool that they don't use right away. You'd think a colonoscopy would be the go-to move, right? But nope. In a massive bleed, it's actually useless at first because the bowel is just full of blood. You can't see anything. It's like trying to find a clue in a room that's completely filled with smoke. You have to clear the air first.
Now, for the less urgent cases, the toolkit is a lot broader. A digital rectal exam is often the very first simple hands-on check. For bleeding that's been going on for a while, a flexible sigmoidoscopy might be the best tool for the job. And then you've got these highly specialized tools like angiography, which they only bring out if a bleed is actively happening. It's all about choosing the right tool for the specific clues in front of you.
All right, so the evidence is in, the lab results are back, and the culprit has been identified. We are now entering the final phase of our mystery, closing the case. And that means connecting the confirmed cause to the right resolution, the right treatment.
And this table just shows you how specific the solutions are. A simple anal fissure might just need a topical gel, but an obstructing tumor, that could require an emergency operation. And for advanced rectal cancer, the treatment might actually start before surgery, with chemo and radiation to shrink the tumor first. Each diagnosis gets its own highly tailored plan. There's no one-size-fits-all here. Okay, we have followed the evidence. We have identified the suspects, and we have seen how the case gets closed. But before we wrap this all up, there is one final crucial clue I want to leave you with, and it might just be the single most important takeaway from this whole thing.
Take a look at this quote. It's talking about a certain blood test, CEA levels, and it says they are indicative, meaning they can point you in a direction, but they are not confirmatory for cancer. And that is a perfect metaphor for this entire mystery. A medical diagnosis is almost never about a single smoking gun. It's all about piecing together lots of different clues, the patient's story, the exam, the lab tests, the images. No one clue ever tells the whole story. Which brings us to our final big question. After all of this, all the suspects, all the tools, all the evidence, what is the single most important clue in this entire medical mystery? The answer? It's the very first clue. It's the sign that something is wrong in the first place. The most important thing you can possibly do is not ignore that sign. Prompt investigation is the absolute key to solving any mystery, but especially a medical one. Getting it checked out is what starts the whole process and gets you to a resolution. And that right there is the crucial takeaway. Thanks for joining me on this investigation. We'll see you next time on The Explainer.